Further ado, I'd like to introduce our speaker for the program. Dr. Christy Morrissey is an oncologist and hematologist of the Valley Hospital and Mount Sinai Comprehensive Cancer Center. Welcome, Dr. Morrissey, and thank you so much.
Thank you. Are we ready?
We are ready. Take it away.
Okay. So hi, thank you everyone for coming today. I'm just going to talk a little bit about breast cancer basics. So we'll review some statistics about breast cancer, talk about some of the common subtypes of breast cancer, and then we'll also talk about screening, imaging, and some kind of recommendations on what we can do to try to prevent breast cancer. All right, so let's go to the next slide. Okay. So a couple statistics that I think are very important, and it's, very paramount when we're thinking about why we screen for breast cancer. So a woman has a 1 in 8 chance in her lifetime of developing breast cancer. And we think in the year 2025, approximately 316,950 women will be diagnosed with invasive breast cancer. When we talk about invasive cancer, that means that the cancer is not confined to either a duct or a lobule, and we'll talk a little bit more about these nuances later, but it means it has the potential to spread to other sites of the body. With that number of 316,950, 59,000 new cases of ductal carcinoma in situ, or non-invasive cancer, meaning that the cancer is contained within the duct and doesn't really have the ability to spread. And about 16% of women with breast cancer are younger than the age of 50. So important things to think about. The one blessing is the death rates in breast cancer have been rapidly declining since 1989, with an overall decline of 42% since 2021. And we can be very thankful that mammograms came out in the late 80s, and that's a lot of the reason that we're having these declines is we are catching breast cancer at a much earlier stage, which has a lot more treatment options. So thanks to early detection, these screenings, improved treatment, we thankfully have more than 4 million breast cancer survivors living in the United States. So those are great numbers. So I think, when we talk about breast cancer, we have to talk about some of the non-modifiable risk factors or things that we cannot change. So we'll start, everyone, ages. We love that, people are getting older, they're wiser, but with all these things, aging unfortunately does increase the risk for breast cancer, and not just breast cancer, other cancers alone. The reason we think is just as we age, our immune system is just not able to be as up to snuff as it was years prior. And we can have cancer cells that our body used to be able to kill all of a sudden kind of escape our own immune responses. Other things that we cannot modify are genetic mutations. So when we think about breast cancer, common ones people hear of often are BRCA1 and BRCA2 mutations. There's other mutations like ATM and some other ones that you'll be genetically screened for if you do develop breast cancer. But I think knowing if you have a family history is very important because it can allow you to get screened earlier and also be on the lookout for other types of hereditary cancer syndromes. Something that I don't think we always talk about is reproductive history and how that can affect breast cancer risk. So starting menstrual periods before age 12 and going into menopause after age 55 exposes a woman's body to a longer duration of hormones. So we think the longer exposure in theory can also have effects in increasing the risk of breast cancer. Having dense breast is another thing that can sometimes be, more nuanced. Dense breast alone, though they might increase the risk slightly, don't really put a woman over an average risk for the most part. Again, if you have hereditary mutations, other things like that. But where dense breasts really have issues is that they can make mammograms very hard to read. So the dense breast can often obscure very small masses, which is why it's very important if you have dense breasts to be very optimal with your imaging, including an ultrasound to try to detect smaller masses that we might not see on a mammogram alone. So personal history of breast cancer is also very important, or other histories of like atypia. So a lot of people will come see me, have a history of atypical ductal hyperplasia, and then we'll kind of talk about risk reduction and other things to try to prevent a cancer occurrence in the future. Like I mentioned about having genetic mutations with BRCA1 and BRCA2, having a family history of ovarian cancer could also put you at risk if it was related to one of those other mutations. So I think one thing that's very interesting is that patients that had a history of Hodgkin's lymphoma and actually receive mantle radiation to the chest, um, they have a much higher risk of developing breast cancer in their lifetime, and they're actually required to have screening at a much earlier age to try to prevent, invasive or other types of breast cancer from developing. Other things, in the 70s, there was a drug diethylstilbestrol or DES that was given to prevent miscarriages. So what's interesting about this is women who took this are at increased risk of breast cancer, but so are the patients that also, the parents, like the mom had a child, that child's also still at risk. So it's very important to really get a very detailed family history when trying to figure out what risk factors a patient has for developing breast cancer. So I think where this all leads to is, when should we get screened and how often should we get screened for breast cancer? So I think something that's very confusing is there's a lot of different guidelines, and who do you trust? Who do you listen to? So I think the one in our group that we really is the NCCN. That's our National Cancer Guideline. And they recommend annual screening mammography beginning at age 40. That's for the average person. There are patients that have, like I mentioned, a mutation that makes them high risk. We would start screening them earlier. The other important thing is that mammography used to just be on its own. Now we recommend it with tomosynthesis, and I'll talk about that in a later slide and how that differs from standard mammography. For the most part, every center you go to now uses tomosynthesis, so it's not really, you have to ask for it. I think, depending on which guideline you use, some say you should stop screening at 75. I do not feel strongly about that at all. I really think where it matters is where your life expectancy is going. If you are active and can have mammograms and could get treated for cancer, if something were to develop, then you very well should get mammograms, even if it's in your 80s and 90s, because you could benefit from that treatment. If you were very frail and couldn't get treatment, then those are risks and benefits to talk over with your provider before scheduling a mammogram. But I think the biggest thing is to just be diligent. Go for your mammograms. These screenings really do catch breast cancer at a much earlier stage. And by going annually, we're giving very minimal time between those screenings to even catch something new or very small before it becomes something that we have bigger issues and have to deal with. Okay, so like I mentioned, tomosynthesis is now pretty much what it is a 3D mammography. So when you try to think about how 3D versus 2D mammography really differs, I think looking at this other picture, hopefully you guys can see my pointer, hopefully. I think what the biggest difference when you look at 2D versus 3D, when you look at a cross section of a rose, is that in the 2D rendering, you really can't see what's going on in the center of the flower. It just looks like a blob. But when you look at the 3D tomosynthesis, you can start to make out the little petals. You can start to see little discrete things here that, let's say this was a breast cancer. In this photo, you're not really going to be able to see anything going on in here. But in this image, you're actually able to make out a much
Mhm.
crisper picture. And what exactly is it, you might ask? So what tomosynthesis does is it takes multiple images in an arc-like pattern and creates a detail image. So when we look here, you see it's going around. It's doing like a circle. So it's a low-dose X-ray. It works the same as 2D mammogram. It takes about 4 seconds, and it's much more sensitive in detecting cancers, especially in dense breast tissue, compared to a diagnostic screening mammogram that only uses 2D. When you look at 2D imaging, let's see, I just want to make sure I can highlight. It's just taking images from above and from the side. So you're missing, again, all of that circular imaging to kind of miss those things in between. So
We
I think,
can see the pointer, by the way.
oh, good,
Sorry.
thank you. But yes, in the past, 2D was the gold standard, but now, we're really promoting that people get tomosynthesis to make sure that we're not missing any kind of minute details. All right, so I think a big thing is that patients often come to see me, and I think what's very important is knowing the anatomy of your breast and what subtypes of breast cancer can develop. So in this image, I wanted to be able to point out what a lobule is, which is right here. This is where the milk actually gets produced in a lactating breast. And then these are the ducts, and the ducts are what carry the milk to the nipple. So when you talk about breast cancer, you often hear people saying that they were diagnosed either with invasive lobular breast cancer or they were invasive ductal, or you'll hear ductal carcinoma in situ. So I think that matters when we talk about the anatomy, about where these breast cancers are developing and how that differs. So when we talk about breast cancer forming in the lobules, lobular breast cancer can actually be a lot more sneaky. The reason is it often forms kind of like thread-like projections where like single cells form the tumor comparatively to when tumors form within the ducts. The ducts themselves usually have more of a mass-like structure. So when I see patients coming and they say, I was diagnosed with invasive lobular carcinoma, the thing I can sometimes notice is when they go for surgery, sometimes those patients will require a repeat excision because sometimes the extent of disease wasn't able to originally be determined accurately on imaging. So I think that's where you can kind of see a little bit of nuance. Both are treated. We'll talk about treatments briefly and how things go, but we treat them generally pretty much the same depending on the subtypes. But I think it's just important to clarify that. And then I think, when we talk about breast cancer and how things travel, it's important to know where the lymphatics and things are right near the breast tissue. So this picture, these little bean-like structures are lymph nodes. And pretty much lymph nodes are our body's immune system's way of kind of like filtering or trying to take infection out, but they also do filter cancer. So the one thing we look at when patients are diagnosed with breast cancer is we will get ultrasounds of the axilla or the armpit to see if there's any enlarged or unusual lymph nodes, because that'll require a biopsy. And by biopsying it, we'll know kind of if that changes any kind of the treatment paradigm. Okay, so I think where a lot of the nuance and why you come to see breast oncologist is how we treat breast cancer. So what I'll tell you is that about 70 to 80% of breast cancer fall into a category called hormone positive breast cancer. And what that means is that the tumor cells express extra receptors for estrogen or progesterone, which is here. And I think one of the misconceptions is that when I see a lot of patients, they're like, well, why does my body make more estrogen or progesterone to fuel cancer? And that's not actually the case. Your body makes the appropriate amount of hormone that it needs. But what your tumor has done, if it's a hormone positive tumor, it's hijacked these receptors, making more receptors on the cancer cell, meaning that the more receptors there are, the more sensitive these tumors are to hormone. So when you have a hormone positive breast cancer, one of the mainstay of treatment is giving a medication, which you might have heard, either tamoxifen or an aromatase inhibitor, and we'll talk about that later, to try to lower the estrogen. In order to kind of be like a normal cell that uses sugar to divide, you're trying to block that estrogen so that the tumor cells don't have any additional food to divide. I think another big thing is when we talk about other subtypes, 30% of other tumors fall into this category, either triple negative, HER2 positive, or triple positive. So what does triple negative mean? So when we look at this breast cancer cell, we see there's estrogen, there's progesterone, there's HER2. When you have a triple negative tumor, it means that your tumor does not have an estrogen receptor, it doesn't have a progesterone receptor, it doesn't have a HER2 receptor amplified, causing cell growth. And these tumors can be much more aggressive. They can grow very fast. So when we talk about this little marker down here, Ki67, that's a marker of proliferation. And what that means is how fast are the cancer cells dividing? And when we think about breast cancer tumors, less than 10% means it's a slow growing tumor. Between 10 and 20 is borderline, and above 20 is high. For the most part, hormone positive can be, above 20 if they're a more aggressive variant, but a lot of times they'll be less than 20. The triple negatives can be somewhere 95, sometimes even 100%, meaning that those tumor cells are just constantly in a cell division, which makes the treatment, a lot more aggressive than what we do for the hormone positive. And we'll again talk a little bit more about what we do for that in a minute. HER2 positive tumors. I think, there's been a lot of press in the recent years about HER2 because we have new targeted agents for it, a drug called Enhertu, which has come out. So I think there's a lot of promise in, we used to always think HER2 was a very aggressive tumor, which it can be, but I think the favorable thing is that we now have a lot of targets to help combat that. And then triple positive, what does that mean? So that means that on this breast cancer cell, the HER2 is amplified, the estrogen receptor is amplified, and the progesterone receptor is amplified, meaning that we have 3 different targets to try to prevent cell growth and kill the cancer cells. So I think, treatment really depends again on the specific subtype. But I think for the majority of patients, if it's a very small tumor, we do a combination of surgery. So surgery options are either a lumpectomy, where you remove just the tumor and this close surrounding tissue until you have clean margins. Some people, though, will say, especially if they have genetic risk factors, they will be like, I'd rather just do a mastectomy. I think a very interesting and, point that I always like to drive home is that when you look at clinical trial data, there is no overall survival advantage to doing a mastectomy versus a lumpectomy. So I think that's things to think about when you're planning these surgeries. Outside of surgery, if you did elect for a lumpectomy, you likely would need radiation afterwards. And then depending on the subtype of breast cancer, the treatment can vary. So I think very nuanced to that. So again, majority of breast cancers are hormone positive. So for the majority of patients, I can wind up just giving pills alone. But there is a very interesting test. It's a genetic test on the tumor called an oncotype. And what oncotype testing does is it gives us a score, and it's all based on clinical trial data. And the goal of oncotype had come from a trial called Taylor RX. And what the goal of it was to see how many patients they could safely omit chemotherapy for and just offer endocrine therapy alone. So when the tumor is greater than 6 millimeters and less than 5 centimeters, you qualify for an oncotype test. If the oncotype comes back, if you're postmenopausal, less than 26, it means that you have absolutely no benefit to chemotherapy, which is wonderful. And it's given us a lot more options with women being able to avoid giving them chemo and then having to deal with those side effects later down the line. And if those are the case, then we give women just endocrine therapy alone, and those can fall into the class of aromatase inhibitor, tamoxifen. And I have a few slides later kind of talking about those subtypes and kind of what they do. But there are certain women with high oncotypes, large tumors, lymph node involvement, triple negative tumors that we do still have to give chemotherapy for. But I am happy overall we've been able to move away from having to give chemotherapy to everyone, which it was in the past. So HER2 positive tumors are interesting in that they have HER2 targeted drugs now. But for the most part, HER2, even very small HER2 tumors, we usually do recommend single agent chemotherapy plus a HER2 targeted therapy. But I think that's a lot of nuance for, I think, this talk. So I think we'll focus more on talking about, the endocrine therapy and side effects and what that looks like. And if anyone has questions on any of this, please feel free to ask. Okay. So I think for the longest time, most people, when they think of endocrine therapy, know tamoxifen. And I borrowed this from the Osmosis organization. So tamoxifen, what it means is a selective estrogen receptor modulator. And I think that's an important, term to talk about and what that means for side effects and how the drug works. So what tamoxifen does, it's a down regulator of estrogen in breast tissue, which is what we want it to do. We don't want any free floating estrogen in that vicinity to drive any future tumor growth. But it actually does the opposite in the uterus. So when you have unopposed estrogen growth in the uterus, it can actually cause endometrial hyperplasia or thickening of that endometrial lining. So it's very important when patients start these medications that if they have abnormal uterine bleeding, anything that doesn't seem right, that they follow up with their gynecologist and let us know so that we can keep a close eye on it. Other things we think about is like, we talk about any kind of endocrine therapy, we try to talk about the side effects and how people will feel on them. Yes, we know the reason we give them is to prevent a breast cancer recurrence, but we also have to know the toxicity that we can cause. Tamoxifen can cause a lot of menopausal-like symptoms, so hot flashes, night sweats, joint pain. It rarely can cause low blood counts, elevated liver enzymes, or elevated cholesterol. But one of the feared side effects with these drugs, like I mentioned, was if you have uterine hyperplasia, it actually can lead you to a 1% annual incident of uterine cancer. But again, the risk is very low. Other things are that these medications can also put you at risk for blood clots. So we always tell patients if you're having any kind of lower extremity swelling, you develop any kind of shortness of breath, these are things you have to let us know imminently so we can best address it. Other than that, people will mention they have mood lability. Sometimes they feel like kind of like PMS, like their moods go up and down throughout the month. They can also mention they feel a little bit more fatigue, vaginal dryness. But I think for the most part, tamoxifen is a well-tolerated drug. Things that you should also know is that tamoxifen is usually our preferred agent in premenopausal women because the other class of drugs, which we'll talk about in a little while, aromatase inhibitors, you can't give patients that still have a functioning ovaries because of the way the mechanism of the drug is. And I'll talk a little bit more about that. But I think, the big key takeaways is that we have wonderful drugs that really reduce the risk of recurrence. So tamoxifen has about a 50% relative risk reduction in preventing a recurrence of breast cancer, which is great. And when we look at oncotypes and scores like that, they tell us when patients take, especially for lower oncotypes, tamoxifen or an aromatase inhibitor, it can wind up reducing the risk of metastatic disease and keeping people at about a 95% chance of not developing metastatic disease for these lower oncotype scores. So I think it's very important to consider taking these drugs. They're highly recommended if we recommend them to you. So I think it's something to just really consider when being referred to us. Okay. So the other class of drug I was mentioning is something called an aromatase inhibitor. So aromatase inhibitors are usually our preferred agent for postmenopausal women. And the reason being is that aromatase inhibitors work by preventing the aromatase enzyme in creating estrone and estradiol. But the issue is that they do not stop the ovaries from making estrogen. So that's how in premenopausal women that still have ovaries, this would actually cause you to increase estrogen production because your body would tell the fat cells that are making estrogen that they're not making enough, and it will tell the ovaries to kick into high gear and make more. So we can only give these medications either in postmenopausal women, or we can make a premenopausal woman postmenopausal by giving her a drug called Lupron. But those are, again, nuanced, and we only really do it if they have a high-risk tumor. When we talk about aromatase inhibitors, there's 3 different ones. I don't know if anyone's familiar with them, but there is letrozole, anastrozole, and exemestane. So letrozole and anastrozole are almost identical. They both work through a non-steroidal backbone. Exemestane works slightly differently. And I think the reason that really becomes important is when we talk about side effects. Aromatase inhibitors, similar to tamoxifen, can cause joint pain, feeling fatigue, some mood issues. They can also cause hot flashes, night sweats, vaginal dryness. If you develop any of those symptoms, let's say on letrozole, which is what I usually start with, I try to push you for about 3 months on one drug. If you really can't tolerate or the side effects are getting worse, I usually will switch you from letrozole to exemestane in the hopes that maybe you will have a better side effect profile. No guarantees, but I think there are 3 in the class, so we can switch around and we can always switch to tamoxifen, especially if you're postmenopausal, you qualify for both. Um, let's see. So I think, the big things that I wanted to talk about, I think I went over briefly, but I think, coming from a breast oncologist, I think, the biggest thing I can drive home to patients is please, please get your screening mammogram. Start at 40, do it annually, even if you don't want to, because you want to catch things early before they have the chance to have any issues. I think, it's very important also to discuss with family if they have any breast cancer history. I think, oftentimes, females will say, oh, but my dad's mom had it, so it really doesn't affect me, but it can. So, male or female history, mom or dad having a family history of breast gynecologic cancers can portend an influence on your life. So, I think learning as much as you can about your past or your family's past can help you in the future. I think another very key takeaway is that it's very important that you examine your breast very frequently. So there's been a lot of different guidelines saying not to do monthly breast exams. And the reason that kind of became out of favor is that what was happening was that women were being told to examine their breasts just once a month. And when you do that, if you don't examine the breast at the same time every month, the density, the texture is all going to feel a little bit different. So it can make you miss things or actually think you have something wrong with you when you don't. So what I usually tell patients is every time you're in the shower and you're putting soap somewhere, you might as well do a breast exam and kind of see where your breasts are and see if you're noticing anything different, because you're going to be the first one that notices something abnormal. And for the most part, you really can't feel a tumor unless it's greater than half a centimeter. But if you're very diligent and you feel something just texture-wise doesn't feel right, that's a reason to go see your physician, have imaging, and always be an advocate for yourself. If you have pain, you have nipple discharge, you have a nipple that becomes retracted, meaning it gets pushed in and it used to be pushed out, these are reasons to get screened and to tell someone what's going on so that they can have a look as well. I think a question I get asked very often is what are the best things for diet, exercise that people can do to try to prevent breast cancer? So I think, healthy diet is the most important. I think trying to eat as minimally processed foods as possible is best. When you look at backs of packages, make sure that most of the ingredients you can read the names of, because there's a lot of chemicals and substances that are put into products that are not good for us. I think the closer to the farm to table, the better it is. Most of your diet should include fruits, vegetables, whole grains, very limited red meat. All we think red meat and cooked meats like that can cause inflammation. Um, Other things is to know is that, things that are great vegetable wise, mushrooms, berries, these are all wonderful for breast health, including soy. So soy used to get a bad rap that it caused breast cancer because it contains plant estrogens. These plant estrogens do not drive human breast cancer growth. But what they can do is actually help with some of the side effects of menopause, hot flashes, night sweats. So I think it's very, very important that patients and everyone try to eat as much soy, mushrooms, berries as they can and incorporate into their diet. Other things to know is that how we talked about aromatase inhibitors prevent estrogen by blocking aromatase, which usually is produced from fat cells or the adrenal glands. The more fat cells you have, the more likely you are to produce estrogen. So it's very important to try to keep and maintain a healthy weight because that will lower your estrogen production, which can be a driver of breast cancer. Other things that are very important with your health and your breast health is especially patients that have to be on aromatase inhibitors, tamoxifen. It can affect your bone health. Tamoxifen postmenopausally actually can help build new bone, while aromatase inhibitors do the exact opposite. So the big thing or the big takeaway is that in order to help build new bone, you have to have an appropriate amount of vitamin D and calcium. And in the United States, vitamin D to get processed into its active form requires sunlight. And I don't know about you guys, but I come here at 6 o'clock in the morning. We leave here almost 6 o'clock at night. I don't see any sun. So it's very important that you take a vitamin D supplement if your doctor recommends it for you. And most patients do get a pretty good amount of calcium. But if you don't think you're getting about 1,000 milligrams a day, then I say you should supplement. But again, this is talking to your doctor. I'm not giving exact medical advice, but these are what I tell my patients. Other things is, we tell patients do not smoke. Smoking is horrible. We know it's a very difficult habit to kick, but it does increase the risk of cancer, not just breast alone. So especially if you take tamoxifen, you cannot smoke because it can increase the risk of blood clots. And another thing that commonly comes up is what to do with alcoholic beverages. So we recommend for women, especially with breast cancer, that they not have more than 3 alcoholic beverages a week. And what that means is that a drink counts as 1 glass of beer, 1 5-ounce glass of wine, so 12-ounce beer, 5-ounce glass of wine, or 1 ounce of alcohol, meaning rum, liquor, vodka. So where people get mad at me is I tell them a martini is actually 3 drinks, so you can only have one of those a week. But I think, in this world, I think one of the biggest things is, just doing everything in moderation. So if you want to have an alcoholic cocktail, I totally get that. But, just try to be mindful and limit where you can. So I think that was most of what I wanted to talk about. But does anyone have questions or concerns or anything else I could answer while everyone's still on?
Hi, Dr. Morrissey. Yeah, that was just wonderful. It was so
Okay.
comprehensive, and thank you so much. Um, I'm sure lots of people, I think those all those lifestyle changes, people, really, I think they appreciate hearing about that. It's kind of in our control a little bit, because
It's nice having
genetics.
control over something. We don't have
Hmm.
control over a lot.
Right. Our family history and genetics, of course, and that's very frightening. But this is so enlightening and encouraging to hear all that and the improvement in the statistics.
Yes.
Um, well, and somebody else was mentioning, can you tell us that website to get the recording again? Oh, that's for me. Oh, okay. Yes. The website to hear this lecture again is www.valleyhealth.com/ tune into health. So it's www.valleyhealth.com with a backslash there, tune into health, one word. Okay. All right, everyone. Thank you so much. Thank you so much, Dr. Morrissey. I really appreciate you being here and hope to see everyone again soon. Thanks again, Doctor. Have a great holiday season.
You too. Bye-bye.
Bye.